I'd like to turn it over to Dr. Stone. And Dr. Stone, thank you. And we look forward to your information.
Hey, thank you for the kind introduction, Travis. So just the title of my talk is Musculoskeletal Ultrasound, another tool in the imaging toolbox. And so just today, I want to talk a little bit about what exactly ultrasound is, and just to give you a little local flavor where we perform our examinations. And then the main point of the conversation today is to talk about some of the relative benefits versus clinical limitations of ultrasound and how it can help you. Ultrasound is a form of mechanical energy, in other words, sound waves. Ultrasound uses a frequency that we can't hear, but the key takeaway for ultrasound is that it doesn't use ionizing radiation like other forms of imaging tests, such as X-ray or CT, and therefore it doesn't cause cancer. We perform our ultrasound examinations for musculoskeletal radiology at Carolina's Imaging Services in Morocroft, which is in the middle of South Park. We perform examinations on Tuesday and Wednesday mornings that require one of the musculoskeletal radiologists to be present. And this is a location where we have our MSK radiologist on site daily from 7:30 a.m. to 9 p.m. We perform rheumatology hand exams and afternoon slots at this location. And we also perform the rheumatology hand exams at the CIS site in Rock Hill, South Carolina. At the location in South Park, we also have a 3T MRI scanner, which is also something to keep in mind, as that is also pretty important for small joint imaging. The Carolina's Imaging Services South Park location is the only site in North or South Carolina with accreditation in musculoskeletal ultrasound by the American Institute of Ultrasound and Medicine. And I have to think this is in a large part because we have a fantastic sonographer at this location, Kelly, who is the clinical supervisor for all ultrasound across CIS. But furthermore, she's been specifically trained in musculoskeletal ultrasound and certified. And she carries 5 years of MSK ultrasound experience at CIS. At this location, you also have a rotating team of our musculoskeletal fellowship trained radiologists who are proficient in ultrasound, myself with Drs. Essenberg, Mahanti, Fergus, and Lopez. So what's in it for the patient with an MSK ultrasound evaluation? We have the patients come in, as I mentioned, on Tuesdays and Wednesdays at South Park, or if it's a common exam that doesn't require direct examination by the radiologist, such as a hand exam, they can be done in the afternoons at South Park or in Rock Hill. The patients are scheduled for a 45-minute time slot. The exam is started by Kelly, and then at the end of the examination, the radiologist will see the patient to troubleshoot specific areas or to complete a non-routine examination. So when you're considering ordering an ultrasound, I think just like any other test, it's important to understand how exactly it's performed, and that helps you understand what exactly you'll get out of it. In contrast to a CT and MRI in which a patient's placed into an imaging machine and you get these series of 2D slices to form a volume or just a 3D volume in general that you can go back later through and reformat, ultrasound is largely limited to real-time imaging and then saved representative images or clips through a particular area of interest. Ultrasound is more like getting, a series of samples across a body part rather than acquiring a volume that you can go back and look through later. And that is inherently one of the limitations of ultrasound, is that, if you're the interpreting physician, or if you're a second radiologist who's consulted on the images, or if you're a treating physician who's not familiar with the modality, you're somewhat limited in what you can go back and analyze. And most of the interpretation comes from real-time evaluation at the time of scanning. The main benefits from ultrasound, as I alluded to at the beginning, are that there's no real risk of energy deposition. There's no radiation exposure, so it doesn't cause cancer. It may have better spatial resolution than CT or MRI, and this is largely dependent on the patient, the location in the patient, and the equipment and transducer used, as I'll get into a little later. It allows positional anatomy and dynamic imaging, which is not really allowed in CT or MRI. It's often less expensive for patients than other imaging modalities, and it's highly specific for simple cystic masses, and it allows Doppler imaging to determine if something is vascular or not, similarly like the way we use contrast in CT or MRI. One of the specific advantages of ultrasound is that because we are seeing the patient in real time, we can image while performing provocative maneuvers. And some of the more common indications we do this for are for subacromial impingement, looking for snapping nerves or tendons, or looking for subluxing nerves or tendons. Here is a representative image from a typical lower leg ultrasound examination looking at the muscles of the anterior calf. And this is just an example of the leg being relaxed. And here we see the fascia overlying the muscle. There's a suspicion for a small hernia right here where we can see some muscle protruding through. But ultrasound gives us a way to confirm that by having the patient standing up and squatting, putting increased pressure on this muscular compartment. And here we can see the muscle protruding through this fascial defect. Ultrasound, of course, has some limitations. One of the biggest limitations is that it cannot see past the bone cortex, so it's limited to the superficial tissues. As ultrasound moves through tissue, the sound waves are attenuated, and therefore we see things superficially better than we see things that are deep. And therefore, it's not as useful for obese patients who have more tissue for the sound waves to go through before they make their image. And then finally, it's limited to targeted evaluation of specific structures. You can't really take in a large volume of tissue at one time like you can on CT MRI to get a big picture. You're more focused on a specific checklist of images and to see small structures individually. So here's just an example of a rib. Here we see the nice cortical outline of the bone. And here's a nice example of being able to see a fracture in the bone, and a little bit of periosteal edema right here as well. So this does show that we can see superficial cortical fractures, although ultrasound is less sensitive than X-ray. But this does just reiterate that we can't see past the bone into the deeper soft tissues. Here's an example of where an MRI was a better evaluation. This patient had clinical concern for peroneal tendinitis, as the peroneal tendon is here along the plantar aspect of the foot. However, the real pathology was that this patient had a trabecular stress fracture within the calcaneus. Ultrasound would never be able to show us that, but MRI allows us to see past the bone cortex into the marrow. So just remember, as sound penetrates tissue, it diminishes in strength, and that's what we call attenuation. Thus, in order to get to deeper structures, we have to use a lower frequency transducer, and we also have to use this on larger patients, and this applies for musculoskeletal applications or abdominal applications as well. Anytime we use a lower frequency transducer, there's a trade-off in that we get lower spatial resolution. And thus, when you have obese patients, again, ultrasound may be limited because of this. One of the main benefits of ultrasound is that we can very specifically distinguish between benign cystic lesions or hypoechoic or low attenuation lesions by other imaging that actually contain solid tissue. Because sound passes freely through fluid compared to soft tissue, we thus see more return of sound waves from behind the cyst relative to sound waves being returned from behind other tissue. And that's what we call posterior acoustic enhancement. That just shows that this cystic portion contains fluid which fully transmits sound, and it doesn't imply there's any posterior enhancement like we suspect with CT or MRI or solid tissue. And therefore, we can tell this is a benign fluid-filled lesion. Another example of attenuation, this is a very thin patient. What we're looking at here is the proximal humerus and the greater tuberosity. This fibrillar structure here is the rotator cuff tendon inserting on the proximal humerus. You can see a nice normal tendon. There's no tear. We can actually see a little bit of articular cartilage here, and there's very minimal overlying muscle subcutaneous fat. And this is just an example of what that same representative image would look like on an obese patient. Here, we can see that there's more soft tissue to get through before we get to the actual bone. Here you can see the outline of the proximal humerus. Here you can see the rotator cuff, you're barely inserting on the humeral head. And this just shows the limitations. There's really not much you can say definitively about this rotator cuff, other than the fact that it looks like it's at least partially intact. Whereas on the other rotator cuff, you could see beautiful images and you would have been able to pick up a partial tear. So the AIUM has numerous indications for ultrasound. And one thing to keep in mind is that there's no real contraindication for ordering MSK ultrasound. So we typically see examinations broken up in several different categories, predominantly rheumatologic indications, orthopedic or sports indications, neurological, and finally oncologic. In rheumatology, we can do ultrasound of the small joints of the hands and feet to detect synovial disease that is radiographically occult. And we do this by using power Doppler evaluation to assess the vascularity. We can also detect mineralization and crystalline arthropathy. So this is a normal example of a proximal interphalangeal joint. Here you see the volar plate, the flexor tendons, and there's no real fluid within the joint. In contrast, this is a joint from rheumatoid arthritis. Here you see that there's loss of cartilage between the bones. The joint space is narrowed. There is increased Doppler signal within the synovium on the joint. Here you see the synovitis on the grayscale images, and here you see the color flow indicating synovitis. Here's an example of the radiocarpal joint in a patient with gout, and here you see reflective mineralized tophus adjacent to the joint. And when we cut on power Doppler, we see something called twinkle artifact, which shows mineralization within this as it confuses the Doppler signal for different areas of enhancement. In sports medicine orthopedics, we're commonly looking for tendon injuries and muscle injuries. And one specific study showed that ultrasound is no less sensitive nor specific than MRI for diagnosis of full or partial thickness rotator cuff tears. And this was in the radiology literature back in 2009. Apart from the rotator cuff, it can be used to evaluate nearly any muscle or tendon in the body. Just with the caveat that the more superficial the tendons are, as I alluded to, the less attenuation of the ultrasound beam and the more accurate the examination will be. So going back to the rotator cuff, again, here's a nice normal tendon insertion of the supraspinatus. As opposed, here we can see the low attenuation fluid within an intrasubstance tear of the supraspinatus. And then these are two examples of full thickness rotator cuff tears. Here, where the normal rotator cuff tendon should be, we see a fluid-filled gap, we see the humeral head, and we see the overlying articular cartilage. So that's a full thickness tear. Here's another example that's a more chronic tear, where instead of the fluid-filled gap, we see the humeral head, we see the cartilage, and this is a portion of the retracted tendon here, and here's the overlying deltoid. So this is just an absent rotator cuff tear from a chronic retracted tendon. And actually done by some of my attendings, Washington University, a study was done to show the significance of using ultrasound for looking for muscle atrophy and fatty degeneration of the rotator cuff muscles, because that correlates with how patients will do after rotator cuff repair. And ultrasound large was just as accurate as MRI, for identifying and grading fatty degeneration of the rotator cuff muscles. Here's an example of an inflamed biceps tendon with synovitis and the long head biceps tendon sheath. Using dynamic maneuvers, here we can tell that the biceps tendon subluxes from its normal position within the intertubercular groove and is related to a bicep pulley injury. One of the benefits of ultrasound as well is that it's useful, is that you have the opportunity to evaluate the contralateral side during an examination. This patient presented with left pectoral pain, and here is the left pectoralis muscle. Well, if you've looked at a lot of ultrasound images, you could tell that this muscle is enlarged and hyperechoic, reflecting edema. But if you weren't sure, you could always take a look at the right side, which is what this is, which shows a normal pectoralis muscle, which shows the internal fibrillar architecture and the normal hypoechoic pattern of muscle. This patient also had an MRI and was confirmed to have delayed onset muscle soreness, and you can see the diffuse edema within this muscle corresponding to the ultrasound finding. Again, this was a thin patient with a full thickness tear of a part of the hamstring origin. And so here you can see the hamstring muscles. You see the semimembranosus tendon intact here to the tibial or the ischial tuberosity. And here you see the fluid-filled defect with the retracted tear of the conjoint tendon. And finally, during an examination, we'll get lucky. Here, just looking at the hip for hip pain, there is a fluid-filled defect within the acetabular labrum. So this patient, was able to have an accurate diagnosis of an acetabular labral tear. But that's, relatively rare. This is the same patient actually who had an MRI arthrogram to confirm, and you see the fluid-filled defect within the labrum, and you can see it much more clearly and more confidently on the MRI. So in the neurological realm, given the spatial resolution of ultrasound, there's potential to have good evaluation of superficial structures such as superficial nerves. Common examinations we evaluate are median nerve at the carpal tunnel, the ulnar nerve at the cubital tunnel, and the common peroneal nerve. And we can look for peripheral nerve sheath tumors, any type of compressive lesion, focal or diffuse neuritis. But it is best when we are looking for superficial nerves in specific locations. Here's an example of a patient with amyloidosis who had this large amyloid deposit within the flexor tendons, compressing the ulnar nerve here within Guyon's canal. Here is a patient with symptoms related to the deep peroneal nerve that was found to have a peripheral nerve sheath tumor, which was also identified on the MRI. But this just shows what the tumor looks like with ultrasound. Here's normal nerve proximal and distal to the lesion, whereas at the lesion you have a focal oblong hypoechoic swelling of the nerve corresponding to the nerve sheath tumor. And in the oncology realm, a lot of the benefit of ultrasound is for evaluating masses and determining whether they're cystic and benign or whether they're indeterminate and require further workup. So this is a mass within the forearm adjacent to the radius that on regular MRI looked like it may be cystic, but ultrasound showed that there was this internal soft tissue with vascularity, and that by definition needed further workup and biopsy. This is an example showing relative spatial resolution of MRI versus ultrasound. This was an examination done for a contraceptive implant within the medial arm that needed to be removed. And here is the MRI that is showing the implant here, but then ultrasound for confirmation, and we actually did a localization of the implant. Nicely, you can see the long shadowing forearm body within the superficial subcutaneous fat. So just some takeaways I think are important when you're considering looking at musculoskeletal applications for ultrasound is that it's most useful for us for answering a specific clinical question. For example, is there a rotator cuff tear? Is this lump a benign ganglion, or is it something that needs to be biopsied? Is the ulnar nerve being compressed or subluxating within the cubital tunnel? I think ultrasound is less useful for nonspecific problems, such as general shoulder pain or hip pain, because a lot of the etiology for pain originates within bones or deep soft tissues, and as I alluded to, these aren't evaluated. In patients with pain, they may often have multiple etiologies, and one of the things that always concerns me is that we may have false attribution of symptoms to visualized pathology that we see on ultrasound, while neglecting other pathology we can't normally see. And then finally, keep in mind, ultrasound examinations are often tailored to each patient. Some examinations that I've alluded to, such as the rheumatology hands, are standardized, like our right upper quadrant abdominal ultrasound examinations. But more times than not, in the superficial musculoskeletal world, we try to tailor each examination to each patient. And the final takeaway is don't be afraid to consult us and ask if ultrasound would be a useful test or if we would recommend something else. And with that, I just want to leave you all with my email address, which is taylor.stone@charlotteradiology.com. And I'll open it up to any questions now, but please feel free to reach out to me at any point in the future, if by email or call us, and be happy to answer your questions at that time. Thank you. Travis, I believe you're muted still.
Okay, now you guys get to hear it this time. Amazing information, Dr. Stone. I appreciate it. With me interfacing with a lot of providers, the question about that obese patient, how often is that patient turned away to another modality? And can you define that patient more so that I could be able to articulate what patient would not fit into the MSK ultrasound perspective?
Yeah, there's no cutoff with that. It's more of just something to consider at the time of scanning, and more times than not, it's often one of the things that once the patient gets here, we'll do the scan and then see that's the case, that we'll try to recommend something else. I think like when you look in literature and you see that MSK ultrasound is always this specific and this sensitive for detecting rotator cuff tears, you just have to keep in mind that that varies depending on the patient. And if there's ever a question where I feel like the examination didn't truly answer the question that it was set out to answer, then we'll recommend something else.
Okay. Also, I call on a lot of providers and they're unaware of the MSK ultrasound. When I stop them, they go, "What?" As a provider, could you give me one thing that I could leave with a provider that might say, okay, this is the patient that you need to recommend this before you go to an MRI?
Yeah. So I think if the patient has a specific area that hurts that is attributable to a specific tendon, or a specific soft tissue focus, if there's a concern for a partial thickness tear of the rectus femoris proximal myotendinous junction, that's a great example to go to to ultrasound. If there's a specific question about a full thickness tear of the supraspinatus, that's good too. There's also, some patients can't get MRI examinations. Patients with pacemakers or other limitations in that regard. Those ultrasound may be the first modality to go to for those patients as well. Okay. And then finally, if there's anything that needs to be imaged dynamically, I think ultrasound is the right examination to go to. For example, if someone feels, it's a common things we see, if someone feels if someone has an ulnar neuritis and they feel their ulnar nerve or their funny bone moving around along their medial elbow, ultrasound is a great examination to evaluate that and to evaluate the small structures there. If someone has carpal tunnel syndrome at the wrist, we get great high resolution images of the carpal tunnel and can evaluate that as well.
Well, Dr. Stone, I'm looking, I don't see any questions, but I probably will get some later on. Thank you for sharing your information with us, and thank you for coming on and letting us know more about the MSK ultrasound. We are very appreciative of your time, and thank you again. And let me check one last time. No questions in the chat. If you have a question, please feel free to contact me or Dr. Stone, and we would be more than happy to give you some resolution to any of your questions. And at this time, I think we're right at the mark. Dr. Stone, once again, thank you. And thank you for all the participants at this time. And look forward to the next webinar. Have a good one. Bye-bye.
Thanks, Travis, and thank you for anyone who listened. Thank you.
All right, bye-bye.